So myeloma is a disease that from the definition is refractory. So you have assumed that after first-line treatment, even though it's very effective, the disease will be back. And after the second line, we have to plan the third line and subsequent lines. That's how it is. Maybe we'll change it in the future, but as of now, we have to plan sequence of the therapy. Sequential therapy means that in the subsequent lines, we should give to the patient the most effective treatment. And the decision what treatment should be used in particular patient should be based on the previous treatments, the response, the toxicity. Unfortunately, we have no that knowledge to predict with 100% that the patient will respond, disease will respond to particular treatment after particular treatment failure. But what we do is that we assume if the patient was resistant to proteasome inhibitor, for example, we rather attempt to change the group of drugs in the subsequent line. So after proteasome inhibitor-based therapy, we are trying to use IMiDs-based therapy, for example. However, this is not for sure. So even the patient was refractory to bortezomib, for example, doesn't mean that introduction of the IMiDs therapy will be effective. From the other perspective, it doesn't mean that the patient will not respond to the proteasome inhibitor. So these are our assumptions. We don't know that yet, but based on the knowledge, based on our expertise, we do plan it and it's summarized in the recommendations. So the recommendations made by the IHA, ISMO will be available within a couple of weeks. They're updated, and they assume that patients with, for example, refractory to daratumumab should receive that and that treatment and shouldn't receive that and that. So this is kind of complicated, but that's how we do plan the sequence therapy in myeloma. Well, as I said, we do assume that patients under continuing treatment with certain drugs become resistant. We have to propose to the patient the most effective treatment in subsequent lines. So that's why we plan the treatment accordingly. So for example, if patients was resistant to daratumumab in the front line, we will not be able to give daratumumab or any other anti-CD38 antibody in the subsequent line. So we propose to give, for example, a monoclonal antibody against SLAMF7, so elotuzumab, or propose, for example, BCMA targeted treatment. And such situations are, there are much more because the treatments now consist of more than 2 drugs. Now in the front line, actually, we should be using 4 drugs. So that's why it is important to avoid, not necessary toxicity by giving the drug which is not effective and give only toxicity. And from the other perspective, we should propose the most effective drug. So to avoid toxicity, to give efficacy, we should look back what the treatment was there and to propose treatment that probably will be effective in that patient situation. So we take into consideration several factors. First of all was the treatment before. What drug were a part of the treatment? What was the response? How deep the response was? How long the disease was in the remission? Was there really true remission? Was only partial remission? Or the patient achieved MRD negativity or not? What is the cytogenetic risk? Was the patient transplanted or not? So all the factors which were related to the treatment that was given before. That's very important. But also, we have to take into the consideration what is the patient's status. Well, we are older, not younger. We are weaker, not stronger. That's how it is with myeloma. So the disease becomes stronger, the patient becomes unfortunately weaker. So we have also take into the consideration what is the patient's status, what is his frailty, what are the comorbidities, what happened during the last treatment, or maybe his status is better, maybe he's stronger because we control the disease. So we have to assess the patient frailty. And also we have to ask the patient what was his favor, what he would like to receive. Well, the knowledge among patients, it's more and more, which we do appreciate. But for example, there are some regimens that are full oral, so that's more convenient for the patient. Probably they are less effective than drugs given sub-Q or IV, but we also have to discuss it with the patient. So it's not only 0-1 system. So after DARA RVD, the patients must receive, I don't know, Siltacil, for example. But there are several options, several factors that should be taken into consideration, and that's our job, right? So that's the knowledge that we have to get. That where we run so many studies, that where we learn so long, right? And also we have to discuss with the patient. So several factors needs to be taken into consideration. I do believe artificial borders should be destroyed, because that's why we work so hard, that's why we do so many research, that every drug that is registered, which means proven in terms of the efficacy and also with acceptable toxicity, should be on the market. That's what I do believe. And every time when I meet with the Polish government representative, I keep repeating that there should be no limitation. I know that the drugs are expensive. I'm aware of that. But, my goal is to give the most effective and the less toxic treatment for the patient that I was trained to, right? So, but yes, answering this unfortunate question, the limitation is a fact. And we are doing what we can to use all available drugs that are on the market to make the whole treatment, the whole strategy, the most effective. We do believe that soon we will have access to the cards. That's the Polish situation. We have all bispecific available. We are lucky, not in every country in Europe all bispecifics are available. Starting April the 1st, we have all 3 of them available, which is great. We don't have cards yet, but again, we are supporting the government institution, giving the knowledge and our support, and also using support of our patients to have the cards available in the next year, I do believe. So again, I would say that in Poland, next year, all immunotherapy will be available, but still they are not yet, so we are not that happy yet. Absolutely, as I said, this is important part. This is not my disease, this is the patient disease. And not every treatment matches every patient. That's what I was saying during my talk, that the treatment should be tailored. And it's not only based on the disease, but based on the patient biology, I mean comorbidities, but also the decision. I remember an old lady that was in pretty good condition, and I was discussing with her giving the sub-Q drugs, but she refused. She said, I live like 200 kilometers from my place. There is my grandson that will take care of me, but I don't want influence on his life. The grandson who was present during this talk, he said, no, I will help you. And then what she did, this old lady, he asked me for private discussion without the grandson. So, well, this is not only, so we live with somebody, we share our life, and we have to take into the, consideration all factors. And I designed a treatment for her that she will stay at home as long as possible with good quality of life. So, some simple issue like to travel from home to the place that the drug can be given can be an issue. So yes, definitely we discuss it with our patient. And as I said, the patients are more aware of the treatments, are more aware of the disease. So they are partners. It's not like I make the decision. Actually, I make the recommendation only. And the decision of the patient is final for me.